Welcome to today's Echo. We'll go ahead and get started. My name is Brian Hendricks. I'm the Quality Improvement Data Analyst at USET. Emily, if you will go ahead and do some housekeeping items.
Yes. Good morning, everyone. If you had not done so already, I'm going to invite you to mute yourself. And please don't be offended if we mute you. This session is being recorded and will be available later today on our YouTube. If everybody can go ahead and share their name and tribal affiliation, citizenship, intertribal organization affiliation in the chat, we're trying to really gauge what kind of reach we're getting with these echoes. And then I'm also going to share a link in the chat, which I will share periodically throughout the hour, which is an opportunity for you to claim continuing education medical credits by attending this session. And so you have to complete the form that I've just shared, and then it'll lead you to a brief evaluation for you to also give us feedback on how we can improve these. And that is all I need to say.
Thank you, Emily. We'll go ahead and get started today with Monty Ransby giving updates on the Nashville area.
Thank you, Brian. Hi, everyone. I hope you're having a great day so far. Happy Friday. I'll be providing my usual update on COVID-19 epidemiology for the USET region or Nashville service area and take a brief look at some of the data points currently included in our weekly USET aggregate surveillance reports. Please note that we do send these out every Wednesday to representatives of USET member tribal nations, as well as USET staff. And these reports primarily consist of information related to COVID-19 testing and vaccine administration. I also want to mention that since a couple of weeks ago, you may have noticed that the reports have looked different. The vaccine portion of the report specifically, as they are no longer displaying some of the tribal level or specific data points you were once getting. We were previously receiving this information from the Nashville area office through weekly reports from sites, but because they have now transitioned to using the IHS COVID-19 dashboard to collect and track this data, we no longer have access to it and will need permission and approval in order to restore it. So that being said, since last week's report, we have been informing and asking tribal nations to provide permission and approval via email reply if they are interested in the USET TEC accessing this data, so that we can again provide you with the information you had been getting previously. And we've tried to make this data request process as easy as possible and are simply asking that in your reply on the weekly reports email that you indicate yes, along with whether you would like the USET tech to have access to just vaccination data or both vaccination and COVID-19 case surveillance data. For those that have already replied granting approval, we should be able to get access to your respective dashboard and restore the information that was previously omitted from your report in next week's report, which will come out Wednesday on the 28th. So on this slide, you'll see the number of new positive test results, the cumulative total of positive test results, as well as a percent positivity. This is for the past week of April 13th to the 20th. So for this past week in particular, the number of positive COVID-19 tests was 42, while the cumulative total of positive COVID-19 tests was 6,082, and the 7-day positivity rate was at 4.5%. We have been seeing an uptake recently, and as many have likely already heard, it looks like we have entered into yet another wave of the pandemic here. So the increase that we have seen in these numbers is also reflecting that. In particular, if you reference the percent positivity from 2 weeks ago to today, you'll see that a clear increase did occur. The percent positivity that I reported on our last echo from the 9th was around 3.5%, whereas this week's we were at 4.5%. So again, from this and more apparent on subsequent slides, you'll notice that we are seeing a rise in the number of COVID-19 cases, and that's within the USET region as well as just nationally. So this next slide shows you the number of new positive COVID-19 test results from week to week over a 12-week period. As I mentioned before, for the current week of April 13th to the 20th, the number of new positives in our USET region was 42. This was only a slight decrease from the previous week where we did see a jump in the amount of cases being reported. With the increases we are seeing, I think it's very critical that we continue with public health prevention measures and strategies used to control the spread of COVID-19. Personally, I am getting a little tired with living in a pandemic situation, but I understand that we cannot truly get out of this without following the guidelines that we have been since the start, including masking and social distancing, and now more recently vaccinating. So I'd just like to say, continue encouraging yourself and others to hang in there. I think I can see the end in sight. So the graph displayed gives you the rate of new COVID-19 cases per 10,000. This is by USET counties, USET states, as well as the United States. And we've also given a 12-week time frame for this information as well. Please note that this data was specifically obtained from CDC and state health departments, and so it is not limited specifically to tribal citizens. We continue to feel that this information is quite useful, and it's been a good indicator for what is happening in and around the USET region. And that's specifically in regards to the number or amount of COVID-19 cases that are being seen locally and then at a state and national level as well. So for the current week of April 13th to the 20th, the PERCTA purchased and referred care delivery area or USET county rate was reported as 18.17 cases per 10,000, while the USET states rate was at 13.52 cases per 10,000, and the United States rate at 14.15 cases per 10,000. In addition, for this past week, the USET county rate was highest, followed by the United States rate, and lastly, the USET state rate. As mentioned previously, and by just glancing at the past several weeks, you can see there have been some notable increases across the board. Although as reported on past updates, the USET county rate is still demonstrating the largest presence of COVID-19 infections at the county level compared to USET states and the United States, as it is highest. There was a slight decrease noted in all rates from last week, April 6th to the 13th to this week. The next few slides will consist of the vaccination data featured in our weekly surveillance reports. It is our hope that you find this information useful in tracking the progress made with vaccine administration at your tribal nation and or in your geographic area or region. In addition, we are also hopeful that this can be used to assist with making decisions related to COVID-19 vaccination programs. So the slide feature shows you the percentage of population fully vaccinated and is broken down by the United States and the Indian Health Service, or IHS. As I mentioned at the beginning, we have not included the data point for reporting facilities in the Nashville area, as that is not available at this time to report on. Please note that these graphs are displaying numbers from the previous week of April 14th, as well as for the current reporting week of April 21st. And the United States and IHS percentages were directly obtained from data retrieved from CDC's COVID-19 data tracker sites. So for this past week, the percentage of population fully vaccinated for the United States was at 25.7% when last reported, and the Indian Health Service at 23.4% for the percentage of population fully vaccinated. So yeah, and from that, you could also see that there has been some continued progress on a national level with vaccine administration, as well as with the Indian Health Service area as a whole, with getting individuals vaccinated there. So this graph that's currently listed showcases the percentage of population fully vaccinated again, but is instead broken down by USET states and the United States. Again, please note that the bar for reporting facilities in the Nashville area is missing from this graph as well. Information from the previous week is also given for this visual so that you can kind of see the percent increase that has occurred from week to week. Percentages for individual USET states appear to range from 19 to 33% for the current week, with about 2 to 3% increases seen from the previous week. And so again, I think this graph also really shows you the progress being made, and particularly in the USET states. This last slide here gives you the percentage of delivered COVID-19 vaccination doses that have been administered. The information for this graph is broken down by the United States. Again, we have USET states combined, and then lastly, the individual USET states listed. Again, you'll note that I've omitted the reporting facilities in the Nashville area bar graph again, or bar again here. I'd say that these percentages demonstrate job being done in getting the vaccine that has been delivered to various states administered to the public, or needles to arm per se. I do want to make note that when referencing all USET states in particular, it looks like a really good job was done for this past week, as it is very close to the United States percent as well. And I just want to end or close by just reminding you to please feel free to reach out to our USET tech team if you do have any questions or concerns. Again, this could be COVID or non-COVID related. We're always happy to assist you, and our email address is usetepi@usetinc.org if you would like to get in contact with us. That being said, thank you for your time today, and I'll take any questions now.
Thank you, Amani, for a great presentation. Do we have any questions at this time for Amani or the USET EPI team?
I have a question. This is Jorge, and that's a great presentation, Amani. The first question is, the percentages of vaccination rates are pretty similar, IHS national, but in your specific area, what is do you know what the reason of not getting vaccinated is? The main reasons at this time?
At this time, I want to say that everyone who kind of wanted to get vaccinated has gotten vaccinated. So the vaccine hesitancy that we're seeing now or left with, again, are the same reasons that were there in the beginning. You know, the expediency of these vaccines coming out, people are scared of that. The history behind vaccinations as well, I think plays a role. But I do want to say that despite that hesitancy, we still have and are making progress. And I'm hoping that, you know, as we move forward and now with vaccinating youth more, that we can reach that group and get some more work done in that area.
Thank you.
Any other questions before we move on? Just a reminder to enter in your name and tribal affiliation into the chat box to help us keep track of attendance. And then we'll go ahead and turn it over to Dr. Mira for his presentation on HIV and COVID.
Can you see my presentation? Yes. Okay, thank you. Before I start, just wanted to comment that I do agree with Imani that we're having, all of us, I guess, pandemic fatigue. But it's the moment that we don't have to let our guard down, because they're not going to have another outbreak. And we really need to educate not only our providers, but the public and our neighbors and everybody we can get in touch with. Yesterday we had a case, we're evaluating it right now, as a fully vaccinated individual who got COVID and this individual thought that the vaccine allowed them to go into work without using the precautions, and this person exposed a lot of people that had to be quarantined. So, just need to make sure that we all understand that vaccines are very useful, but they're not perfect, and we still have to be careful. Okay, so I'm going to talk a little bit about COVID and HIV. So the first part, or many of the slides, since they were already built, I got them from clinicaloptions.com, and the other slides I made based on an article that was published in Current Opinion in HIV and AIDS, which is a very thorough review. So just before we get into HIV and COVID, a brief summary of the immune response in COVID-19. So an individual gets exposed to SARS-CoV-2, the virus binds to the ACE2 receptor, is internalized, and then it's presented to the monocyte or macrophage, which starts the immune response. And a lot of cells are involved in this immune response, which includes CD4, CD8, T cells, and neutrophils. And depending on how intense that immune activation is, that will determine the course of the disease in that individual person. So it is important to highlight that in the initial phases of this immune response, the production of interferon is critical to decrease viral replication or not. So if you have a good interferon response, probably you will control viral replication and your outcome is going to be fine. If your interferon response is not that great, then virus replicates more and your immune system may be more activated, and that's what causes the deleterious effects down the road. So if the immune response after viral clearance is mild, you usually go to recovery without major complications. If your immune response is very exaggerated and you have a cytokine storm, that may lead to severe lung damage and damage in other organs, which in some individuals, 1 to 2% ends up in death. So an adequate immune response has to be timely, has to have a good interferon response initially, and an interferon is produced by the macrophages at this stage right here. And then you have to have good activation of your B cells, so you produce neutralizing antibodies and control the infection. An inadequate immune response is that you don't have a good interferon 1 response, or it's delayed. There's a lot of endothelial damage and leakage, and there's an overactivation of your natural killer cells and T cells with a lot of cytokine production, and that's what causes severe inflammation in organs, especially in the lung. So I don't want to make this a spoiler, but the CDC comments that having a weakened immune system may increase the risk of severe illness from COVID-19, but there's limited data to suggest that persons with HIV and viral suppression have the same risk for COVID-19 as persons without it. So what I'm going to cover in the next few minutes is what is the data that's out there and why is it a little bit controversial depending which article you read. So the questions are HIV positive individuals more susceptible to SARS-CoV-2? Is HIV a high risk factor for COVID-19 progression? Meaning you got infected, now what? I mean, do you have a higher risk of having a severe disease compared to HIV negative individuals? Is there any effect on antiretroviral therapy in susceptibility and outcomes of COVID-19? What is the impact of COVID-19 on the HIV epidemic? And what are the lessons that we learned from the HIV pandemic that helped us manage the COVID-19 pandemic a little bit better or faster? So this is a summary slide, and then I'll cover some of the articles. So initially, when the pandemic started in Spain, specifically in Barcelona, they reported their first experiences with HIV and COVID, and they found that the patients who were HIV positive, especially the ones who were on antiretroviral therapy, had less infections due to COVID-19 compared to their HIV negative counterparts. But this was a small study, small samples. And in Madrid, and different city in Spain, they reported the same thing, that there was less infections, COVID infections in HIV individuals. But when they took away the healthcare workers involved in the equation, actually the difference was not so. They couldn't find any differences. In France, they did not find a difference. This is the beginning of the pandemic, very small cohort. In China, they did not find a significant difference in HIV and COVID susceptibility. And the Veterans Aging Cohort Study, which I'll give a little bit more information, they did not find that a difference either. So, most of these studies either have small samples or heterogeneous populations regarding the HIV population. And initially, many were on ART. Many of these patients had access to healthcare. So there may have been more testing in this subpopulation compared to HIV negative individuals that usually do not have, a bond with a healthcare venue in particular. Then regarding outcomes, most of the studies at the beginning of the pandemic, again, were small studies, small samples, except for the Veterans Aging Cohort Study. And the other problem with many of these studies is that the populations were heterogeneous. The ways of diagnosing COVID was different. So it's different. It was difficult to compare. But when they looked at comorbidities, that seemed to be the main driver of bad outcomes in the HIV individuals. So it wasn't the HIV itself. It's just that these individuals have a lot of other comorbidities that do have a worse outcome with COVID-19. So this is the VA, the Veterans Aging Cohort Study, and they looked at 253 patients who have HIV and COVID-19 with people with HIV and no COVID-19, and then HIV and infected individuals with and without COVID-19. So they had a very nice cohort to look at. And just on the chart on the left, you can see that people in the comparison they did, people with HIV were 30,000, HIV negative 76,000. But when they looked at infection rates, this on the bottom line here, there really wasn't a major difference in susceptibility to COVID-19 if you were HIV positive or negative. And then when they looked on the graph on the chart on the right on hospitalization, ICU admission, intubation, and death, there also was not a statistically significant difference between HIV positive and HIV negative individuals in this pretty large cohort. In Spain, also a very large cohort, 77,000 individuals with HIV that were receiving antiretroviral therapy, 236, this is the beginning of the pandemic in February of last year, were diagnosed with COVID. And they did not find an increased risk of COVID-19 diagnosis, but they did, in this particular study, that they did find that people with HIV had higher mortality compared to HIV negative individuals. The problem with this study was they didn't take into account all the confounding variables such as comorbid conditions. So we don't really know if people with HIV had more obesity or more cardiovascular disease compared to the other group. And the outlier study is the one from South Africa, in which they do, if you look at this is a big chart, but if you look at the bottom line, HIV negative or positive, people who were HIV positive in South Africa had higher mortality compared to HIV negative individuals when they had COVID. The problem with this particular cohort is that it did not, so 55% of these individuals were not on ART, and there was a very high rate of tuberculosis in this group, and that was not accounted for when they did this statistic. So it could be that comorbidities such as other lung diseases were actually the driver of mortality, but we don't know. So this is something to be cautious. But at the end of the day, even if you account for that, people with HIV and comorbidities have a great mortality. So this is a more precisely designed studies. It's a cohort that looked, a multi-center study that looked at 404 individuals with HIV and COVID-19, and they matched it to 49,000 individuals without HIV and COVID-19. And when they did look at all the covariables like body mass index, diabetes, hypertension, COPD, etc., mortality was not higher because you were HIV positive compared to HIV negative. So the bottom line is that individuals with HIV have a lot of comorbid conditions. And this is a survey done in UK of people with HIV that are 50 years of age or older. The majority were on antiretroviral therapy, but they had a lot of comorbid conditions. And in this graph, what you can see is the x-axis is the age groups, and then the different colors in the columns are the number of comorbidities that these individuals have. And when you are approaching higher ages, as expected, the number of comorbidities would dramatically increase. So it is not unexpected that today we have a lot of people with HIV that are older, and that's thanks to good antiretroviral medication. They've survived many years, but they have all this other medical problems, and they're more susceptible to a worse outcome with COVID, not necessarily because of their HIV infection, which the final word is still not out there, but because of the comorbidities they have. Switching gears a little bit, so does ART, antiretroviral therapy for HIV, have any effect on COVID? So there were two studies that came out with some flags that there may be some antiretrovirals that may be protective against COVID, or patients with COVID have better outcomes if they're taking these antiretrovirals. And the antiretroviral specifically is tenofovir disoproxil, not the TAF, but the TDF version. So in this study that came from Spain, this is the same cohort study that I showed you before, looking at incidence of COVID. What they looked at was different antiretroviral regimens and what was their outcomes. And what they found is that people that were on TDF had a better outcome compared to any other antiretroviral regimen. Now, there could be a bias here. I mean, there certainly are biases. And the first one is that TDF is usually your first-line regimen. So when you see people that are not on TDF, then it might mean they have other problems, like they have chronic kidney disease, or they failed therapy, and their HIV disease is a little bit different. So have that into account. Also, in the South African study, they found very similar thing, that individuals that were on TDF compared to other antiretrovirals had less mortality. But again, the same biases apply. Usually, this is one of your first-line regimens. So if you're not on a TDF regimen, you're in a second-line regimen or third-line regimen. And that gives you a hint that maybe you're HIV disease, or you have other comorbidities that may be causing the problem. But to answer the question, there is a trial ongoing that's comparing TDF, FTC, or Truvada with hydroxychloroquine with TDF plus hydroxychloroquine. I mean, this was started a while back. That's why hydroxychloroquine was included in this regimen, and also placebo. So I do not think we have the results of this study yet. It's being done in healthcare workers. So when we have the results, we'll see if TDF offers any protection in particular against COVID-19. Okay, so we talked a little bit about the risk of COVID-19 and HIV, and then the outcomes. So what is the impact of COVID-19 on HIV regarding HIV susceptibility, meaning risk of acquiring HIV because we're in the middle of a COVID-19 pandemic? So the pandemic may decrease the number of HIV cases initially at the beginning of the pandemic because of lockdown. So if you're locked down, you don't have the chance to mingle around and have sex as much as when you don't have a lockdown. And that may cause a decrease in HIV infections, but that is very short-lived according to most experts, because then what kicks in is the socioeconomic the worst socioeconomic conditions that the pandemic is leaving, and those are social determinants that put you at higher risk of acquiring HIV. So a survey done on it's LGBTQ, that's a typo. LGBTQ community over, worldwide, 138 countries from April through May of 2020. This is a self-reported, survey. And the interesting thing is that almost 58% of the individuals that were surveyed report employment insecurity. 44% experienced reductions in salary, 23% reported new food insecurity, and 1% reported having exchanging sex for money or resources. And we know that all these determinants, unemployment, lack of food, etc., are drivers for increasing HIV infections. What is known about the COVID-19 pandemic and HIV testing and prevention? In that same study I mentioned on the LGBTQ study, 50% of the individuals reported uncertain or no access to PrEP, uncertain access or no access at all to PrEP during the pandemic. And a study in Boston from a big PrEP clinic, looked at over 3,500 people that they had enrolled in their clinic when the pandemic hit, and there was a 72% decrease in PrEP initiation, almost 300% increase in refill lapses, and a decrease in PrEP users by 18%. Now, some of these PrEP users in this study reported that they were not having as much sexual partners, and that's why they stopped PrEP, but others were because it was difficult for them to access the clinic due to different circumstances. In San Francisco, it was reported that a 40% decrease in HIV testing citywide, 90% decrease in community-based HIV testing, and 70% decrease in testing for STIs. In Boston, they also reported 85% decrease in HIV testing. And one of the big problems that was reported across the board was that contact tracers for HIV and other STIs, especially syphilis, had been deployed to COVID-19 contact tracing. So we did not have enough, personnel doing the jobs that they were doing before the pandemic. What is the impact of COVID-19 on HIV treatment? So, the pandemic introduced a lot of factors that potentially affected treatment access. So many clinics, HIV clinics, their providers were deployed in COVID tests. Some clinics even closed. I can give you our own example. During a month and a half or two, we were not seeing any patients in the clinic. We switched to telemedicine. And although most of our patients had access, not all of them had access to telemedicine, or it was more difficult for them to have access. So hospital, clinics, and personnel dedicated to HIV were redeployed for COVID-19. In places in major cities where public transportation is key for individuals accessing services, they were not available due to lockdowns. And as I mentioned before, the socioeconomic vulnerabilities that increased during the pandemic drive people into situations in which other priorities arise, like having a roof over your head or eating, and that takes precedence over getting your medications. In another survey this was a worldwide survey, 20 countries, 10,000 MSM, of which 1,000 had HIV, reported that 20% of people with HIV did not have access to their usual providers, any providers at all, and that only 14% had access to telemedicine. And of course, this depends on the type of countries, the economic, socioeconomic situation in different countries. And almost 50% had not been able to refill their HIV medicine remotely. I didn't put the data here, but it's expected that in third world countries, there are going to be 300,000 deaths in the next year due to a lack of HIV medication. Not necessarily because they don't have the medications, just the access to that medication. And in San Francisco, going back to our state, a city that in our country, 31% increase in the odds of unsuppressed viral loads despite care through telemedicine. So despite that they were able to retain and care through telemedicine, not everybody was taking their medications as they were in the past and were becoming virally unsuppressed. And we know that that has several deleterious effects. One on the individual. I mean, you're prone to more opportunistic infections and systemic inflammation, and also on HIV transmission. If you're not suppressed, you can transmit HIV. And unfortunately, but not surprisingly, the homeless were disproportionately impacted by the pandemic regarding their HIV care. So, this graph or this table summarizes there was more susceptibility to HIV due to the pandemic. Prevention services have decreased, testing has decreased, and treatment access has become more complicated. So we really need to try to intervene as quickly as we can to resume all these services to mitigate the negative outcome that this is going to have. And finally, what were the lessons from the HIV pandemic for the COVID-19 pandemics? And the list is very long, and I do recommend you read the article that's cited there in Current Opinion HIV and AIDS. It has a detailed discussion of this. But racial ethnic disparities that we found in COVID, we had found 20, 30 years ago in HIV. So that was not a surprise. Now, many of the regulatory and approval processes for new medications were achieved during the HIV pandemic. I can recall how AZT got a fast track approval in the 1980s, although it wasn't a great drug, but it was the first one we had. And that was due to a lot of activism from the HIV community, from the gay community in particular, that made the FDA change their rules. And the same regulatory and approval processes for diagnostic tests were a success achieved during the HIV pandemic, and which benefited the COVID-19 pandemic. Also, the HIV pandemic made possible for many research laboratories worldwide to be established, looking not only at viruses, but in immunopathology. And that certainly helped speed up, the vaccines research and the antiviral research that's ongoing right now for COVID-19. And the public health response is, contact tracing, we've had it for years. We just had to expand it and take it more seriously with COVID-19. But as I mentioned before, many of the COVID-19 the HIV contact tracers or the STI contact tracers were redeployed for COVID-19. So the HIV pandemic had many lessons that many of them were taken well or adopted in the COVID pandemic. Unfortunately, many others were not. And this is why we had such a sluggish, first year of the pandemic, of the COVID pandemic. So in this slide, there are some CDC and some NIH recommendations regarding HIV and COVID-19. Basically, I'll leave them there for you to read, but basically is that right now we don't have any evidence that HIV and COVID, that being HIV positive puts you at a higher risk of infections because of being HIV alone. Now, the comorbidities or the social determinants that these individuals may have, that puts you at a higher risk of COVID-19, but apparently it's not the HIV in itself. Same for outcomes. Once you have COVID, what determines your outcome, apparently from what we know today, is comorbidities and other risk factors more than HIV. Now, I would personally assume that if you have a person that's very immune compromised, has very low CD4 count, and has uncontrolled HIV viral load, you would think they may do worse. But on the other hand, you need a good immune response to have a bad outcome not a good response. You need an exaggerated immune response to have a bad outcome with COVID. And maybe that's protecting some of these HIV individuals, that they can't mount that cytokine storm. But this is not really known yet. And both guidelines recommend on making sure that people with HIV have access to treatments, and people without HIV have access to prevention. So in conclusions, to date, evidence does not support that people living with HIV have a higher susceptibility to SARS-CoV-2, and I'm sorry for the typo. In Europe and in the US, literature does not support worse outcomes for individuals with HIV and COVID, but there's that South African cohort that did show more mortality, but maybe the lack of matching for confounding variables may explain why they have that high mortality. And COVID-19 is leading to decreased HIV care and testing, prevention, and treatment, hampering the end of the HIV epidemic effort. And we need to get back on track on that. And I'll be happy to take any questions.
Thank you for a great presentation, Dr. Mira, again. Do we have any questions about HIV and the COVID-19 for Dr. Mira?
I do have a question, but it's unrelated to HIV. Have you heard anything at all about approving Pfizer for 12 to 15-year-olds? I know that they applied, I believe it was early last week, and I have not heard anything on the progress of that, a timeline. And I spoke with Dr. Brown on it. And he said, when they got their first approval, like we heard updates about where they were and when they were expecting it, but it's been radio silence about the 12 to 15-year-olds.
No, I have not heard anything. Same information that you have.
Why is it by age and not weight for vaccines?
Well, I mean, I can give you my best personal answer is that, vaccines elicit an immune response. It's not like a medication that has a absorption, distribution, and toxicity depending on your weight. So I think that's the difference. But that's just my first thought on your question, not that I have read that or not. And one thing I didn't mention I didn't cover it because it was pretty lengthy, but vaccines and COVID vaccination and HIV COVID vaccination is recommended to HIV individuals regardless of their immune suppression or regardless of their viral load or ART treatment. And what we don't know yet is what is the response in different subgroups of individuals with HIV and different CD4 counts. I would expect that the response will be lower if your CD4 count is very low. But that should not be a deterrent to vaccinate, because even if you get a 20% or 30% response, that's better than 0% without a vaccine. There are ongoing studies on this. The results are not out there yet.
Do we have any other questions for Dr. Mira? And just a reminder to fill out the survey that's in the chat box. It'll give us some good feedback for future COVID clinics. And if we don't have any more questions, or if we have no more questions, we can go ahead and end and have a great weekend. Thank you all.